Oh, good, thank you. So I'll just briefly add my acknowledgement to the country, to everybody else that's done it today. And for me, it's important to acknowledge the elders past, present, and emerging. And I just like to add my support to that cause. What I'll be talking about today is a little bit of a emergent subject in the field of medical research in general. So it's about ethnographic research in medical fields and a specific subset of that, which is called video-reflective ethnography. I'll briefly touch base on the project that I did as part of my PhD, which was the DECIDE project. And then I'll focus my presentation on some of the challenges from the researcher and institutional perspectives. And then I'll hopefully have some time for a few questions. So when we talk about let me just see, you're seeing the screen. So if I put this down or just move it up, that might be better. When we talk about the ethnography in medicine, generally it's a novel term that has occurred in the recent decade because of the rise of the video technology. And what the value that this particular qualitative approach brings is that it really helps us see the full complexity of medical care as it happens in a particular context. So really the things that people who are concerned with studying the perceptions and behaviors of some of the challenges, this is where those kind of the video observational methods are very useful. They also help us unpack what are the mechanisms, what are the instruments that help or drive the perception, that they drive the adoption of change, and that they drive all the different things that make the healthcare the way it is today. And they also help us pinpoint why something is effective or not effective. I guess medicine has traditionally been a very quantitative focused field. So the question is why we're even looking at those alternative approaches to doing research in practice. Why is it important? And for me, the quote that I have on the screen really sums it up. It's from a recent UK Medical Research Council that looked at the evaluation of complex interventions. And it basically says that the quantitative approaches alone cannot help us answer the questions that go beyond the research effectiveness. So on the next slide, please don't get scared. I will just briefly touch on the philosophy or the scientific philosophy and the different research perspective. They're the dreaded questions that if you're ever going to enhance into a higher academic study, you always ask, what is your ontology or epistemology? So this is a very simplified overview of what that means. And the best way how, for me, it makes sense to interpret it, where I'm trying to explain to somebody the different perspectives that exist. So when we talk about the different views that exist, the basic, I like to imagine it as a scale, and that is a continuum. And in one corner, you have quantitative research, which a lot of our audience should be familiar with. And on the other side, you have qualitative research. Now, what that differs is that the philosophical views or perceptions around what is knowledge and how we create it differ. So in quantitative research, it's quite common. We have a single reality that's easily measured, an absolute truth that can easily be justified and presented in figures and numbers. On the other side, and there is obviously many variations in between. So, you know, if you're familiar with the mixed research or constructivist research, that will kind of sit somewhere in the middle. But on the other side, we have things like relativism, which is the ontology that accepts that multiple realities exist, and that what we perceive to be true is really based on where are we within the context and time, and what are our surroundings, and also that we create knowledge by constructing it through our interactions with others around us, and within how we assign meaning to things depending on what point we are in. So to put that in plain language, for example, a hospital, as human beings, a hospital will mean different things to us at different points in our life. So it's a very different thing that when you go into hospital to visit somebody who has just delivered a baby, or it will mean something else if you're going to visit a relative that's elderly or sick, or if you're going there because somebody has had an accident. So this is the kind of the variation that we talk about when different realities exist and the different contexts exist. So enough about the philosophy of science, which brings me into the particular research method that has recently gained popularity that I have used in the organization that I work in. It is called video reflective ethnography. This particular method originated in Australia in the early 2000s. And what makes it different from common ethnographic or anthropological research is that traditionally researchers would go and bring a camera in and observe a particular phenomenon of interest, and then produce a well-polished representation of what account is. So whether they observed a particular culture or they observed a particular action, they would collate that, produce findings, and then provide detailed description of different aspects of what they were researching. The video reflective ethnography carries slightly different intent and slightly different steps. So you do have that traditional video ethnography that observes a particular item of interest. So within the healthcare context, whether you want to explore how clinicians communicate, how a particular action is done, this is where you do your video collection. The second part of this methodology looks at video reflexivity, which is then asking the people who were filmed to come back together in a reflective session and view themselves on film. Viewing themselves on film actually allows them opportunity to reflect on how they go about doing their everyday things, and that in turn leads to improvements to practice. So this method has been used in many different settings across many different continents. Most commonly, we have used it in a healthcare setting to cover different range, as I said, clinical communication, infection control practices. It's been used in dementia care, palliative care, cancer research, and even beyond healthcare. There were some recent studies that have come through in education in examining the cultural practices of Indigenous populations in Australia. Now, in terms of specifics, what was it interesting that stuck out to me in some of the studies that were used was, for example, one video reflective study looked at how students correctly put the PPE during in preparation to enter a patient's room. Another one was looking the specimen evaluation from a moment that the specimen is collected from surgery in all its pathways it makes through the pathology and then back to the surgeon, which was really important about the timeliness of things. And some different things that are a bit more abstract is patient-clinician dynamics in psychiatric ward, or hospital room designs and impacts on patient care. ICU was another example where it was used. So very, very varied context where this approach has been used. And also, as you can see, because this is the conference focused on around the ethical concerns, it is working with some of the most vulnerable populations that we have in our organization. Which brings me a little bit to my study that we've done. I've used this specific method to explore how clinicians decide to prescribe antibiotics in the emergency departments and what were the challenges. I will not tell you the answers. I have put here the published study that just recently got published. It's open access and it's free for you to go and have a look at it. But basically, it looks what are some of the factors that help clinicians decide whether to prescribe antibiotics, whether to use the oral or intravenous designs. And it's quite a good little discussion about sometimes it is factors that focus on the context, factors that focus on other aspects of busy clinical environments that dictate the antibiotic prescribing that go beyond the electronic guidelines that most of the medical experts are familiar with and use in their everyday setting. So this is a little snapshot of what it looked like. So I've used over a 3-month period during COVID. We were situated in 2 emergency departments on Gold Coast, one in Robina and one in Southport. And we basically followed a group of junior doctors to look at their discussions, prospective discussions around antibiotic prescribing, and collected all the factors that decided whether a person was to be treated at home, whether they were going to be discharged, admitted, and etc. This is probably a context that many people are familiar with. And the one thing that I have walked away from is the incredible complexity and the decision fatigue that our clinicians face on a daily basis in order to make rapid decisions based on the limited information that's available to them at the time. So I walked away with enormous respect for the amount of care and the quality of care we have in across Queensland Health. Which brings me to the core of my presentation. So if we think about using a particular method that I've just described, so video reflective ethnography, and I've tried to capture some of the essential differences between the research and organizational, I guess, priorities. So as a researcher, some of the key factors that we would be concerned with is things like whether I will be able to facilitate adequate stakeholder buy-in. Will my ethics application be processed in time? Because I have spent many months preparing the research side of things. I have perhaps had to apply for funding and I'm keen to start. So there are different, and I want to manage a project within a limited time frame. So those are some of the pressures that the researchers are concerned with. In more nuanced part, there's a question of consent. So which plays a big part. Will the person be given appropriate information? How to get a continuous consent with appropriate levels, which is really important when we use the video images of whether it's participants or patients. How do we how do we navigate organizational politics? How do we store and access data? There's a lot of procedural items that a researcher follows, part of the institution or academic setting. And then there's also things about being concerned with academic reputation and personal integrity to make sure that that is protected and adhered to. And then some of the little things is that sometimes a question we get, what about the Hawthorne effect, or the effect about people behaving differently when they're being filmed, and etc. But overall, the researcher generally has a single focus or a small number of project focus, and their focus is on making sure that the study continues on time and there's least disruptions and they capture the data they need in order to analyze it and then publish further. On the flip side of that coin, the organizational bodies or the HREC governance teams really have a different set of priorities. Some of them align, some of them conflict, and that's okay. So in terms of considering, is the research, of course, of sound methodological quality, and is it ethical? They have a whole lot of legal and regulatory requirements that must be followed that are not necessarily, that are generally more stricter than in academic world. They are also seen as the custodians of the patient data, and they have to uphold the privacy and respect the autonomy that a lot of the public generally has when it uses the health services. The consent is the one that is also concerned. Have the adequate consent approvals been, the process has been adhered to. Similarly, it is with the data and the access and protection laws and processes. And they also try to adhere to the reputation is very important to protect that and ensure that everything is done appropriately. And the difference is that those organizational bodies, you generally tend to have a wide worldview, or you look at a broader set of every research that happens within the organizational context. So in terms of the question, what's next? I guess part of my presentation was a little bit to raise awareness of these are the video ethnographic or video observation methods are gaining popularity within the healthcare, and it's likely that they will be increased in the future. So being aware of some of the different aspects that this research is currently happening is important, but also there are some new innovative methods that are also emerging, which are really fascinating for me as a researcher, and perhaps something that others should be, thinking about. One really cool one is at the moment happening in Europe, where the focus is on pediatric teams wanting to unpack the quality of super users who use the ultrasound to do the cannula insertions in pediatric patients, and how we capture that knowledge so that we can train effectively in simulation, but also in situ practice, how we can train clinicians. So they're wearing smart glasses and they're using a whole lot of different video devices to capture that. Another cool study is using artificial intelligence and facial recognition in the public spaces in the hospitals where cameras are already in 24/7 use in order to pick up perhaps different things. So one is to pick up, for example, potentially aggressive patients or public members, that they can be de-escalated and reduce the risk to occupational harm and risk to the staff. And another one is perhaps being able to pick up on really unwell patients in time to increase it. But overall, the future of the video observational research is likely to increase, but is also likely to be highly regulated and more focused on impersonal and collective privacy. So I will stop there. Thank you very much for listening, and I will stop sharing my screen, and I'm happy to answer any questions if we have time.
Thank you, Mila. That was great. And as a layperson, I just really appreciated your philosophy of science section there. That really helped me a lot. There is one question that we probably got a little bit of time for, asking, do you consider each person in the reflection phase brings to the process their professional knowledge, as well as personal practical knowledge, as well as their values and belief systems and worldview?
Absolutely. None of them are separate from who we are. I guess generally in medicine, you are used to having silos. So you have a medical field and they're focused with one thing. You have a nursing team and you're focused on a different perspective. When you bring people together, the biggest, what I call like aha moments, is that we kind of know how we go about things, but we don't necessarily stop to think why we are particularly good at something or why we do things a particular way. There's always an inherent logic behind the way things are done, but we physically don't see ourselves performing a task. And on a positive side, being able to do that allows us to see the things we do well, but also allows us to, without others having to tell us, we also know when we have cut the corners or we haven't done something appropriate, and we can self-correct. So our values and beliefs, our professional identity, the people around us, that is all included in the mix. The video observational research, especially the reflective sessions, really help bring people together around the same cause, where we operate at the forefront of the full complexity. We don't try to reduce it and turn it into graphs or linear or make it a structured. We actually acknowledge this is where we operate, this is where we deliver care. How then we figure out a way to move forward amongst all of that? Hope that answers the question.
That's fabulous. Thank you so much.